Hello, I'm Janice Karen, Director of Integration Technologies at the Massachusetts Health Data Consortium, or MHDC. I run our Data Governance Collaborative, also known as the DGC. We start each of our weekly meetings with a series of industry quick updates to learn about new and proposed regulations, laws, standards, industry initiatives, and other activity. Join us for this week's updates. Excuse me, if you go ahead and move to the first slide. So the first, this is sort of breaking news, but the White House has announced that they are going to end the formal public health emergency on May 11th, 2023. It's kind of a strange date. I'm not sure why they chose it. This actually means they're going to extend it one more time for about an extra 30 days. And this will have a bunch of consequences. Some telehealth codes will stop being accepted by CMS, and some other exceptions and exemptions for CMS payers will likely end. It's not clear if what other consequences might flow from that perspective. One of the big ones is that there have been some exceptions around prescribing controlled substances via telehealth. And so there are officially some rules about having to have some in-person care, and I believe that those exceptions and exemptions go away when the public health emergency ends. For some of these, there might be some runway. It's not clear. A big one is the HIPAA enforcement discretion for telehealth. While most places have moved to HIPAA compliant technology, there is technically still leeway in terms of the equipment that's available in order to support telehealth during the public health emergency, and that enforcement discretion definitely goes away when the emergency ends. And the big one that affects everyone, if as appropriate, or as things come up rather, is that stuff like the free COVID testing, getting free tests mailed to you, picking them up at pharmacies, stuff like that, vaccines, treatments, etc., will likely end. Obviously, the specifics of what each payer chooses to do is going to be up to the payer, but getting reimbursed for those from the government will end. One thing to note is that the telehealth payment parity requirements in Massachusetts actually have already expired. The ones that are going to expire, the last one actually expired at the end of last year, which was for chronic care and primary care. The only thing that remains, which was put in permanently, is a requirement for payment parity for behavioral health. So you can find the initial announcement. It's kind of buried in a legislative policy position paper on some legislation that was related to the immigration policy and some other stuff that would be affected by this. So they kind of buried it in that policy paper, but these are the official dates as outlined. Any questions there? All right, let's move on to the next thing then. Were you able to get to, okay, great. So another new thing, our friends at MHQP and SHIA have put up a new primary care dashboard. It actually is really a report at this point in time. It's not interactive, but it has some nice information. And what it basically does in most cases is compare data from around 2018 or 2019, usually, to data from 2020, 2021, 2022, usually. And so for each metric, the old date and the new date is different. And there are one or two where they don't have an old data to compare to. And then they had these four categories: finances, capacity, performance, and equity. And for the first three, they basically do this comparison in anywhere from 5 to 10, usually, metrics that they've picked. And then in equity, what they do is they look at various things by race. So there were a couple of interesting things there, and I do recommend taking a look at it. There's a press release from MHQP, as well as a link to the actual PDF file, which is the dashboard at the moment. But most of these are not surprising, because what ended up happening for this report is that a lot of the comparisons were from a just before the pandemic year to a during the pandemic year. And so things like access to care dropped. Well, duh, that's kind of a no-brainer. And performance metrics dropped a bit as well. The biggest thing was that I think some of the more interesting stuff in the is that the population of, they looked at the population of primary care physicians and some metrics around that. And they're definitely aging. And there are more folks that are over 60 years old now than in 2018. And it seemed like there was some data around some of the things that younger doctors in general are not choosing to go into primary care. Obviously, that's a gross generalization, but in terms of the averages, that appears to be true. The other thing that I thought was kind of interesting on the equity measures, and there were 5 or 6 of them, what was interesting was that there was and this too, there was a comparison, and there was a drop in for either Black patients or Hispanic patients, but not both. Or there was one case where there was only one of the cases where it was both. And the gap is widening. So it was kind of interesting. There were places where Black patients were close. There was one case where Hispanic patients did better than other patients. But so anyway, it was just, I found the way that broke out kind of interesting. So I recommend taking a look at that PDF file. That's the second link if you're interested in learning more, looking at the specific measures they provide. And I believe that there are some plans to turn this to have more granular data and turn this into something closer to an interactive dashboard moving forward. Any questions or comments there? All right, moving on. So we've talked about the NIST cybersecurity framework before, and I think we talked about an RFI that they put out last year related to this. And they've gone sort of one step further, though it still reads like an RFI, but they put out something that they're calling a concept paper. And it's really sort of designed at it's a high-level document. It's about 14 pages long. And it's really designed to gather thoughts on their approach and some of the stuff that they want to, some of the ways they're planning to focus prior to drafting an actual proposal, which I think they're planning to do sometime in the summer. It doesn't cover all of the proposed changes. It's really sort of an approach. This is our approach. This is the stuff we're thinking about. This is why. What do you think? What are your suggestions? So their opening feedback is open until March 3rd. Any feedback that's sent in will be publicly posted. So if you choose this is a 2-slide thing, that's just why there's no link. But if you choose to follow the link and take a look at it and have any comments, be aware that anything you say will be public. So some of the things that they put, I thought that they talked a little bit about the framework, and then most of what they spent were sort of the goals and approaches of the new version. So the basic idea of the framework is to help organizations understand, manage, reduce, and communicate their security risks. And it's used across the world, across all sectors. And basically, this is a major upgrade to the framework that's currently in use. So some of the approaches and some of the things that they put forward as important to them in moving to this version 2 was that they scope the framework so that it can continue to be as widely used as possible and not only be useful in particular sectors or particular types or sizes of organizations. They also seem to want to tie it in more to the industry wider and also to other NIST work. So they wanted to use resources that were available online and point to things rather than incorporating everything. They also wanted to provide more implementation guidance in a variety of ways. And if you'll go ahead and go on to the next slide, Dave. But they also wanted to remain technology and vendor neutral and reflect changes. So part of the pointing to the online resources is incorporating other work, but it's also a way to keep it current without having to go through continuous upgrade or upgrading frequently or an onerous process. And so this sort of seemed to be that focus of sort of integrating the wider world and keeping things updated, remaining neutral and vendor technology organization sector neutral, providing more implementation guidance. And then the last area was sort of being a little bit more data focused, actually. They talked about a new govern function, which, so the framework actually has functions and then categories underneath the functions. And so the functions are things like, plan, secure, and then underneath that it might be identity proofing or authentication. So they're putting a new govern function at the high level and then putting stuff under that to help you understand how best to govern this process and incorporating into all of that measurement and assessment. So I thought the approach was pretty interesting. It's actually pretty similar to the way that we look at the world, being, vendor neutral, being accessible, trying to incorporate all of the meaningful players together and making it work for everyone. So I liked the approach, but anyway, you can find the document there. And like I said, you have until March 3rd to comment. I don't know if anyone has any questions or comments. I know, Dave, you've worked with this framework a bit. I remember you bringing up comments when we talked about it before.
Yes, Janice, just one quick thing. High trust certification, I believe, relies on the CSF framework for its categorizations and all that. Did they make any mention of that, of high trust certification, or the time frame on when these changes might go into play?
I didn't see it. I didn't see anything. This really was meant to be an overview. I think that,
Yep.
they talked about the next steps. I mean, they're putting their goal is to put out a proposed, like the equivalent of a proposed rule, like a proposed framework in the summer. So presumably at that point, there'd be another comment period. My guess is it might be a little bit longer because that's obviously going to be a much longer, more detailed document than this one was.
Right.
So I could be wrong, but I can't see how it would happen before the end of the year.
Yeah, and I presume anybody who's already high trust certified, I'm just going back to that because that's what a lot of people in healthcare are concerned about.
Right.
Would continue to be certified under the existing framework, even with the new one, and then I suppose they could get recertified under the new framework if that's the case. So yeah.
I didn't get the impression that there was like any kind of like forced upgrade march type thing.
Yep.
But more of we expect this to be a real improvement. We're going to start by figuring out what the next things are, what is the right thing to do, what we want the next steps to be, what we think the follow on from the existing stuff should be. And then, we'll sort of from there, we'll branch out and see how that flows into other work that we do.
Nice.
Or that other people do relying on the framework.
Great. Thanks. Great update.
Yep. Anyone else have any comments or thoughts or questions? All right, then let's go ahead and move on. So this is the last item for today. Health Gorilla put out an interoperability survey. I thought it was an interesting survey, but you'll see it's not a very large survey. They had 130 executives, and they were split among health systems, EHR vendors, digital health developers, and laboratories. So they couldn't have had very many from each. So I would take the specific numbers with a little bit of a grain of salt. The margin of error is very high. But I still think it sort of gives you you can take it kind of at a high level guideline of what at least a group of people are thinking. And not very much of there's very little of it's really surprising. So even though I would say, it's not a large enough survey to take specific numbers, very seriously, the fact that more than half of the people were reporting that they got duplicate or incomplete data when they used HIEs is not exactly shocking. The fact that about 70% of people doing digital health apps see gaps in their data is not exactly surprising, except that maybe that number seems a little bit low. One thing that they didn't provide a number for this, which I thought was a little bit weird. But they said that most health system execs support TEFCA, which again, TEFCA, despite its attempt to have some inclusion, really is designed for health systems. So that makes it, it's more in line with the stuff that they're already doing around HIEs and stuff like that. So that makes sense. Again, I wasn't sure what to make of this next one, because again, that number is on the low side, I would think. But CIOs supporting exchanging data for non-treatment reasons. Now, I believe most of these are already things that they're supposed to be doing anyway. So, except for the research one is optional, but take that as you will. That next one, the last two I thought were actually very interesting. A third of the digital health apps rely on an intermediary to get their data. They can't get it directly from the health system or wherever the original source of data is. And so whether that's an HIE or some other intermediary, it wasn't clear whether what that always was, but they couldn't get it directly. And then there were a bunch of things on the lab front. And again, we don't know how many people from labs were in the 130. But so this could, well, it can't be one person because of the other percentages they gave, but maybe this is, a couple of people. But 10% of the labs believe that none of the data sharing mandates apply to them. So that was an interesting piece of data, even though it's only 10%, that's still, something that stood out. So you can follow the link and see the rest of the results. This is probably about, I don't know, a third of the stuff that they highlighted in the press release. And again, it's only, it's not a large number of data points, and those data points are split among the 4 groups. And a lot of the results were split by group. So that makes the sample size even smaller, but it was still kind of interesting. Any comments or thoughts?
Janice, I would just,
Yes.
It's a little bit, it's not surprising, but it's a little alarming that CIOs payment and operations are HIPAA criteria for exchanging data, and covered entities are expected to exchange data when it comes to treatment, payment, and operations. So to have CIOs at
also
this level,
individual access, that's patient
and
request.
individual access has now become, the information blocking rule as of end of last year. These are all baked, and some have been baked for a very long time.
Yep.
So the idea that we do see this with health plans trying to get data for quality measures and having to do chart reviews and things like that, but that's no longer permitted. This kind of exchange is supposed to be much more free-flowing, and again, people need to hear this multiple times before they understand that it applies to them and not everybody else. But 58% is a pretty high number for senior IT executives not to know what their information sharing obligations are.
Well, that's 58%, so 42% not understanding, because that's the 58%.
Okay, I misread that. Yeah, so 42%
that's
not
still high,
understand.
though.
Yeah.
No, I agree.
Half, roughly, given the margin of error, right?
I mean, I think if there's one overwhelming thing, again, a lot of these surveys are too small where you can't say, is there a real difference between 58 and 50? Is there a real difference between 60 and 70? You don't really know. But you can sort of take trends. And I think that one trend that's apparent throughout all of these surveys is that there are a lot of people who don't understand the rules, who don't understand their obligations, or don't understand even some of the again, going back to HIPAA, even, which has been around for almost 30 years now. They don't understand, even in that aspect of what's supposed to be freely shared.
Janice,
yes.
Could I interject? So this is Janice Bocchini from
Hi, Janice.
32. Hi, guys. Thank you for this again, as always. I just wanted to interject just to provide a little bit of context that certainly this data is collected for quality reasons, but it is specific to the need to know piece of the HIPAA law. I just wanted to sort of call that out to make sure you know, it isn't misunderstood as not being HEDIS related or direct care outcome related. So I just thought it might be important to mention.
Sure, but they're actually, the laws now are actually broader. So there definitely are, you know, with some of the newer rules, you know, the rule is that, especially if Denny brought up information blocking, with information blocking, if you request data, unless there's a reason they're not supposed to share it, they have to share it.
Yeah, no, that's fine. I just want to say that we still kept in the spirit of that, though.
Yep,
That was all.
yep,
Yeah.
yep. Thank you for commenting on that. We appreciate it. Anyone else have anything they'd like to say about this? All right, then if not, if you'll go on to the next slide, Dave, and pause there for a moment. Thank you everyone for attending or watching if you're watching online. I hope you learned a lot from our quick updates. If you're interested in finding out more about the DGC and its other activities, email me at dgc@myhealthdata.org. That's the email address that's on your screen right now. And thank you again.